Welcome to the discussion of the Uworld question ID 99686. The patient is male, he is 34 years old, and that's all what we got on patient history, personal history. He is complaining of abdominal pain. We analyze this complaint. It's in the lower left abdomen. The onset, he didn't mention when did it start. The character is sharp. It's radiating to the groin. It is associated with vomiting. He vomited twice. This vomiting is related to the severe pain because the severity of this pain is unbearable by the patient onwards. Associations: there is no burning with urination, there is no fever. Burning with urination have a medical term called dysuria, and there is no fever. This absence of fever somewhat excludes urinary tract infection as the cause of this pain. There is no urgency or frequency. It's not mentioned. I don't know if it's present or not, but in actual clinical practice, if you have any suspicion about urinary tract involvement, you would have asked about these things. Is there fever? Is there urination, burning with urination? Is there urgency or frequency? You would ask about these associations. What's urgency? Urgency means the sensation of immediate need to go to the bathroom. The frequency means the number of times he goes to the bathroom would increase in such cases. So you would ask about these things. It's not mentioned, urgency or frequency, it's not mentioned, but you as a physician, you would ask about these things. You would also do an examination after taking a thorough history. So by examination, you would ask the patient to go to the bed or to sleep on something so you can inspect him or do the clinical examination, the medical examination on him. So by inspection, you would see a general condition of the patient and see, you would describe him, is he well or not, but he cannot lie still, he cannot sleep over this bed. Why? Because he will start feeling like discomfort, he will start feeling the pain, he's in pain, so he might have not be able to do what you're asking him to do, to lie still on the bed. Anyways, you try to do the examination, you inspect the mucous membranes, like his eyelids, his tongue, his oral cavity, and you see dry mucous membranes. Why that happened? I assume it's related to the bouts of vomiting he had earlier. So he's not well hydrated. So he starts losing a lot of fluids. This might have caused some form of dehydration. There is no cyanosis, no clubbing, no edema. I'm not sure why did he emphasize on this or why did he mention it in the case. Because I'm assuming like he's building the question. Someone is building the question who would put these things for a reason. I'm not sure what is the reason, but maybe clubbing is related to something related to end-stage renal disease. If it's related somewhat to the urinary tract involvement, the clubbing happens to be associated with end-stage renal disease. Edema as well somewhat is related to nephrotic syndrome and stuff like these, but it's absent in this case. And as well, cyanosis. I'm not sure what cyanosis is doing here, but maybe there is something related to pulmonary renal syndromes. I'm not really sure. I'm just making expectations or assumptions, which might be wrong. By inspection also, the genitalia is normal, and by palpation as well, the genitalia is normal. He didn't mention anything about this in the case, neither in the explanation, but I'm assuming that normal genitalia by inspection and palpation is mentioned to exclude the testicular torsion as the cause of this severe pain. The pain is very, very severe, unbearable, so you would try to exclude testicular cause like testicular torsion by warmth, pain, tenderness in the testes, and that's it. Soft non-tender abdomen by palpation is as well to exclude peritonitis, like organ perforation or something. Maybe this severe pain is due to colonic perforation or any cause of perforation. But it's not happening in this case because the abdomen is soft and non-tender. There's no guarding, no rigidity, nothing of these is present. By auscultations, there is normal lung sounds and normal heart sounds. I'm still not sure why these things are mentioned in particular, but as I said before, lung sounds might be related to the fact there is something called pulmonary renal syndrome. Heart sound and urinary tract associations, the only thing I can think of is mitral valve prolapse in cases of polycystic kidney disease. That's the only thing I can think about, but I'm not sure why is it mentioned. Maybe it's mentioned due to congestive heart failure things and volume overload. I'm not really sure, but anyways, it's normal, so it's of no value of mentioning it's normal. Just normal examination. We assume everything is normal if he didn't mention anything abnormal about it. So, these symptoms we analyzed: pain radiating to the groin, the abdomen is soft, non-tender, no other abdominal abnormality, with this typical character of pain is related to stones. So you want to diagnose stone in kidney, in urinary tract infection, stone in urinary tract. So first thing you need to do is to confirm that there is a stone. How would you do that? You have two options. You either use ultrasonography or you use CT scan. Ultrasonography is used for pregnant women. There is no other option, and you'd use it for low likelihood of alternate diagnosis. It might be less accurate than non-contrast spiral CT, but if it's positive, then it helps a lot because it's less expensive, less radiation exposure. It depends on the technician. It might be false negative, but keep that in mind. You use ultrasonography as a starting point. There is also non-contrast spiral CT, helical or spiral CT, and non-contrast. You don't use contrast CT. One of the options mentioned contrast CT. This is the wrong answer. We don't use contrast. We don't want to use CT as well. So why aren't we trying to start with ultrasonography first? Because low radiation. So using CT is avoided. What about contrast CT? This adds extra side effects, not just radiation, the contrast side effects. So we try to avoid it as much as possible. And non-contrast CT is enough to see the stone, to visualize the stone. So why would I give him the contrast? There is no need for that. So it's always a wrong answer for stone diagnosis to choose contrast CT. Okay, you use ultrasonography, you use non-contrast spiral CT. In pregnant women, you would always use ultrasonography. There is no CT, no radiation allowed. After confirming the presence of the stone, you start thinking, what is the type of the stone so I can treat it accordingly? How would you do that? You would do a urinalysis. This urinalysis would show the type of the stone. What is it? Calcium oxalate? Is it ureate? You'd see that and treat accordingly. And one of the options mentioned urinalysis and urine culture. You wouldn't do urine culture in cases of urinary tract infection, except in case of urinary tract infection. This is just a stone. Urinary tract infection include fever and signs of infection, like elevated CBR and ESR and all these things, and white blood cells in urine as well. So you do urinalysis and see the type of stone. He excluded it. He didn't mention anything about urinalysis is used to determine the type of the stone. I don't know why he didn't mention this in explanations, but in actual practice, that's what I'm expecting to be done. How do you manage this? Just keep in mind that this patient, he cannot lie still, he's in severe pain, unbearable pain. You should give him an analgesic first. You give him ketorolac. This drug is non-steroidal, it's really strong, so this pain can be relieved somewhat. You increase hydration, you ask him to drink a lot of fluid, more than 2 liters per day. This is enough. This would allow the passage of the stone according to its size. You decrease sodium intake. You avoid salty foods, and depending on size, if it's small, below half centimeter, it will pass spontaneously just by increasing hydration and decreasing sodium intake. If it's from 0.5 to 0.7, you would give tamsulosin and nifedipine. These drugs relax smooth muscles, allow the passage of the stone. If it's larger than this, till 2 centimeter, half centimeter to 2 centimeter, you'd use lithotripsy, which is sound waves. They divide or fractionize the stone, allow it to be small enough to pass through the urinary tract. If it's larger than 2 centimeter, this requires surgery. And that concludes our discussion of this question. If you have any question, do not hesitate to leave it in the comment section. Thank you and good luck.